Good evening, everyone. Welcome you all to another wonderful session of Oncology Classroom. Today evening, we are delighted to have Dr. P. Vijay Anand Reddy sir, who is the director of Apollo Cancer Institute, Hyderabad. He is not only an acclaimed oncologist in this country, but he has been revered for his excellent academic acumen, research skill, and oration skill across the globe. It's my honor to have sir today in this session of Retinoblastoma, Current Concepts of Management. No talk on ocular oncology can be complete without him, as he has immense contribution in this country behind ocular oncology. He has also been part of the American Brachytherapy Society for Ocular Oncology Services, and he has been one of the collaborators for the same. And he has a lot of seminal work on this field, a lot of publications in this field. Sir has also been the president of Association of Radiation Oncologists of India, which is the largest body of oncologists in this country. Welcome you, sir, to this wonderful session, and we are really thankful to have you here. It's our privilege that you agreed to take this session. I request you to take over the session now and start your lecture. Thank you for being with us.
Good to see you, Srinivasan, and many others, students. Always smiling, guys. Srinivasan, nice to see you, guys. You've been very active in the ICRO, and I'm so glad that you're leading the ICRO in such a rightful way.
Thank you.
We had several sessions. I wonder and congratulate Dodal for doing this wonderful class sessions across apart from so many CME programs that we have, the ARO is organizing, but still this class definitely certainly helps the younger generation. Now we have growing number of PG students across the country. So NB, DNB, so many DNB and MD students. I'm sure they would get benefited with these wonderful classes that Dodal is arranged. And I'm happy to tell you that Dodal is recording these things and is putting on the YouTube, and whoever misses this, and you can ask your colleagues to check the YouTube at a later date to see if they have missed for some reason these classes. So without much ado, briefly, last time we had a good session on role of brachytherapy in ocular tumors. So in continuation of that, we will be talking about retinoblastoma, which normally in most of your centers, I'm sure you hardly see such cases. And when they are referred to you for any kind of a treatment, then most of the people, they get puzzled, they get confused what to do, how to treat these ocular tumors, because the experience of even the seniors in the institutes have been very, very meager. So it becomes difficult. And these days we should be ready with this information and how to deal with this kind of tumors. It's good that we have these kind of classes also apart from the common cancers like head and neck and carcinoma, cervix and rectum. So let's start with today's class. So briefly on this, the global burden of the disease is around 2 to 4% of the childhood malignancies that you see. I should minimize this screen. Yeah, right. Okay, I can push this away so that. All right. Thank you. Now, the Indian is certainly a little more than the global disease burden. It falls around 5 to 7% of the childhood malignancies. And again, the incidence also, if you look at 2 to 5 cases per million under the age of 5 years globally, whereas in India, it's almost 10 cases per million below the age group of 4. So on an average of 1 in 15,000 cases of live births, you find retinoblastoma. This is our own data. That's what we see. Okay. Now, again, Indian incidence around 1,500 to 2,000 cases, what we see per year in our country. And India accounts for surprisingly 1/4 of the total retinoblastoma cases in the world. which is quite surprising and astonishing. So you should be aware how this disease behaves and how we should manage these patients. So almost 25% of these cases unfortunately present in an orbital form. Orbital means the tumor is out of the globe of the eyeball. So that is called an orbital retinoblastoma. So advanced tumor at initial presentation continues to be a problem in our country, and that is a problem to deal with these patients whenever we think about the globe salvage. So retinoblastoma registry in India, it's very difficult in our country to have this kind of things, but fortunately, National Cancer Registry Program was established in 2012, almost 8 years back, which involves population-based cancer registries of 5 corners in the country and hospital-based cancer registries, which are 29. So approximately, they predict that there are 1,000 cases of male as well as female. That means almost 2,000 cases of retinoblastoma every year. So this is our paper published in February 2019 based on the epidemiology. There are no racial predilection, what we noticed, no sex predilection, no eye predilection. Right and left are commonly almost similar, mostly unilateral, which constitute around 65 to 70%. Bilateral, unfortunately, are also quite high. Almost 1/3 of them are bilateral, what we have seen in our series. Genetics are very important. We should all know that it is familial, but unlike the belief that most of these are familial or hereditary, most of them are sporadic. So hereditary nature was identified in 1962. Stellard noted deletion of D chromosome, chromosome 13, locus of deletion 14 band on the long arm of 13th chromosome was noticed. Intact gene protects patients from getting retinoblastoma. So the RB susceptible gene, which is RB1, is a tumor suppressor gene, and RB1 is an autosomal dominant gene. So RB to occur, both genes should be mutated. So I'll come a little bit of more details because some postgraduates are there in this group. So what happens is you have a germline mutation and a somatic mutation. So germline mutation is the one which is transmitted from the parent to the inherit. It is inherited to the next generation. So the first RB mutation from mother or father, and subsequently the patient passes on this RB mutation, whether he exhibits the disease or not, but he passes that mutation to his progeny again. So this offspring has an increased risk of developing retinoblastoma, as this trait is transmitted as an autosomal dominant with high penetration of 90%. Does not mean that every patient who receives this gene will develop the disease. I'll come to that in a little later. So they also have a significant increased risk of secondary tumors. When you have an RB1 gene mutated in your body, then you are prone to develop other malignancies. So you might have seen patients coming to you with an osteosarcoma, and when you test the molecular status, some of them do find RB1 gene. So we have some other cancers, PNET, melanoma is also having RB1 gene. Sporadic retinoblastoma is in where there is no hereditary component here. The mutation happens after the childbirth in the somatic cell. So that means that these tumors automatically develop after birth, not related to their parents. And these, and you all know, the somatic TILs will not be transmitted to their progeny. So in 1971, Knudsen was the first to say two-hit hypothesis of tumorigenesis. The reason why this explanation was called for, when it is an autosomal dominant gene, when it transfers from parent to the child, why every child will not get the disease? So that explains here this double two-hit hypothesis. So one-hit germinal mutation that affects all cells is transmitted from the parent to the child. There should be a second hit somatic in the retinal cells. So somatic mutation has to happen in the retinal cells of a newborn child. Then only you develop this disease that is called hereditary retinoblastoma. In other patients which are sporadic, that means which develops de novo, both hits happen in the somatic cells. So there is no hereditary component here. Both the somatic hits happen in the somatic cells. So there is no risk of second non-ocular tumors in these patients. they are only retinoblastomas, they are not prone to develop second malignancies in the future, like osteosarcoma and other diseases. So there is no risk of transmission if you have a sporadic. And fortunately, unlike the belief that the retinoblastomas, what we see commonly, are all sporadic. 95% of them are sporadic. Only 5% or less than 5% are familial or hereditary. So when you have an unilateral retinoblastoma, 90% of them are non-hereditary. That means they are sporadic. It happens de novo. Only 10 to 15% are hereditary if a patient has got a unilateral retinoblastoma. But if the patient has got a bilateral retinoblastoma, you should be more often, almost 95 to 99% of these patients are familial or hereditary. That means the patients got this disease transmitted from their parents. So the pathogenesis, originally in 1864, way back, they thought that the tumors have arisen from the glial cells, hence they called it as glioma by Virchow in 1864. Subsequently, Flexner and these are the two guys who believed that it is arising from the neuroepithelium and called them as retinoblasts. Finally, it was accepted as retinoblastoma way back in 1926 by American Ophthalmic Society. So this is how the disease is. You look at the massive tumor here with the fluid behind. This is called subretinal fluid. In a cross section, you see a massive tumor here, and this is a gross specimen of a enucleated retinoblastoma. So the pathology is microscopically we divide them into grade 1 and poorly differentiated. So well differentiated and poorly differentiated, and nothing like intermediate here. So it's grade 1, well differentiated, and classically you find rosettes and florets, first described by Flexner and Wintersteiner way back in 1894, and poorly differentiated tumors, you do not find this rosettes formation in poorly differentiated tumors. There are small round cells with large hyperchromatic nuclei and scanty cytoplasm. So this, you look at this rosettes formation, rosettes and florets around the vessels, around the connective tissue, central lumen with the rosette formation. Plenty of this rosettes and florets all over is a classical of retinoblastoma. See you see this? So there is plenty of such around the vessels, the forming rosettes we call well differentiated Flexner, Winterstein rosettes formation. These are the poorly differentiated retinoblastoma, large cells, pleomorphic nuclei. So you see, don't find the rosettes, very rarely you find rosettes here, but most of them are highly poorly differentiated large cells with pleomorphic nucleoli. So this is one thing which is very, very important. I've seen some of our clinicians asking for a biopsy when they were asked to treat a patient of retinoblastoma. So biopsy is, in other words, it's criminal. You are seedling the intraocular tumor into an extraocular tumor by doing a biopsy. So we do not expect a biopsy to be done in an intraocular retinoblastoma. So diagnosis is purely clinical, no biopsy is required. Examination under anesthesia with extended ophthalmoscopy is required for retinoblastoma diagnosis and staging. Entire thing is done by ophthalmoscopy only. Today, these days, we have what you call in ophthalmoscopy is done by a RETCam. This is a digital wide-angle retinal imaging device. This makes it possible to capture the entire retina from the ora serrata. So this retinal photography is very, very important for documentation, education of the patient and family, and for future comparison. Every 3 weeks, every 6 weeks, we do ophthalmoscopy and see if the tumor is responding or not. So it is mandatory these days to have in ocular oncology department. Nowadays, this is a new thing which has come, a RETCam mobile-based one. This is a gadget which has got an C-arm, which you directly see the patient with your mobile and you can take a picture. So now it is available and it just costs 11,000 rupees. So examination is very, very important. As I said, this is because basically a diagnosis is made on this. So classically, it appears as one or multiple nodular white or cream-colored masses, often associated with increased vascularization. They can be endophytic and exophytic. Endophytic means the tumors are growing into the globe. So the one which we have shown here, this is an endophytic tumor with the fluid developing on the back, subretinal fluid. So tumor grows anteriorly into the vitreous cavity, whereas exophytic growth more posteriorly infiltrates into the retina, choroid, and goes into extrachoroidal tissues. So diagnosis is, apart from the ophthalmoscopy, you have an ultrasound, you see the multiple tumors within the globe, and a CT scan and an MRI is required most of the times. So ultrasound, we call it as most often the B-scan ultrasound is done. It defines the height and thickness associated with retinal detachment, and calcification are also can be identified by a simple ultrasound. It has got a very small probe and it is put on the temporal side of the child, and then we do the ultrasound. So these are hyperechoic masses with calcium and posterior shadowing on the B scan of the ultrasound. This is classical of an ultrasound finding of retinoblastoma. So, and computer tomography, CT scan to demonstrate the presence or absence of the calcium. Most of the times you find the calcium deposits within the tumor, and that also gives a size by doing a CT scan. But mostly we try to avoid CT scan because these are children, small children. We do a MRI scan under anesthesia to evaluate. It also gives you more details of optic nerve involvement, which is very, very important. Very rarely it involves the bone, so CT scan is not of great benefit. So MRI is the way to go. Extraocular extension, and also that if you have any changes in the brain, CSF involvement, meningeal involvement, and the third retinoblastoma, what you call it as trilateral retinoblastoma, will accidentally be found, especially in hereditary form of retinoblastoma. So MRI is obviously preferred modality, especially because these are kids. Bone marrow examination and lumbar puncture are also mandatory when the tumor is, intraocular tumor is big, when you call it as group 4 or 5 or group D or E as per the latest classification, to rule out CSF metastasis as well as bone marrow metastasis, bone marrow involvement. So we sometimes do have problems in the diagnosis by clinical examination. There are so many other differential diagnoses, but this is a rare phenomenon, and most common what we have is a congenital cataract and a coarse disease which can mimic retinoblastoma. Now the clinical spectrum, you'll be surprised to see, especially in India, you have from intraocular tumors to massive extraocular tumors, especially people coming from the rural background. So staging, basically we follow the new international staging system. Stage 0 is what we need to address more often than the rest of the stages. Stage 0 means the tumor is within the globe. Now stage 1 is also tumor within the globe, but when you're doing an enucleation, you find microscopically there is no tumor outside the globe. Stage 2 is when you find microscopic disease outside the globe. It's called stage 2. So you have stage 0, stage 1, and stage 2 for intraocular retinoblastoma. Stage 3 means there is an obvious on a CT and MR a tumor outside the globe. It's called stage 3. And stage 3B is if you have a nodal disease in the preauricular or cervical node extension. Stage 4 is obviously metastatic disease either in the brain, CSF, or in the bone or anywhere in the body. The classical, what we were, when we were in medicine, we were doing medicine, we were taught about Rees-Ellsworth classification. Now the latest one is new international staging system followed throughout the world. Now this is the Rees-Ellsworth classical retinoblastoma. You all know about it. We used to look at disc diameters in the past, group 1 to group 5, which is now converted into group A to group E. So there are some changes again based on the prognosis of the characteristics of each group varies by prognosis. So group A is less than 3 millimeters in diameter is a group A, which can be easily dealt by local therapy, which is done by an ophthalmologist. Group B is also tumors which are more than 3 millimeters, But if the tumor is even less than 3 millimeters, if it is near the macula, it is group B. When the tumor has got some amount of subretinal fluid, then also it becomes group B. And if you have subretinal seeds, which are small tiny seeds behind the tumor, then you call it as group C. And you have vitreous seeds, which are in the center of the globe, then you also call it as group C when they are focal. But you have multiple seeds, vitreous, whether it is subretinal or in the vitreous, it is group D. And group E is a massive tumor filling the 50% of the globe with hemorrhage, neovascularization, glaucoma, extension into the anterior chamber. We call it as group E. This is the latest international grouping of intraocular tumors, and we all follow this internationally. I'm proud to say that we started the department way back in 2003 when we were sporadically getting cases from different parts of the country. We thought, why don't we have a specialized ocular oncology services at LV Prasad Eye Hospital in association with Apollo Cancer Institute. In 2003, when we started this, now the referrals have increased. Now we are almost treating 200 plus patients every year, new patients. So at any given point of time, we have around 600 to 800 patients on treatment at Hyderabad. So this is our own data, which we published in 2020 recently in International Ophthalmology Journal of 2,000 odd eyes with 1,457 patients. So 836 patients had unilateral and 622 had bilateral. Normally, there are only 15% of them are bilateral, but if you look at here, it's almost 40%. That's because we are a tertiary care center. Patients with bilateral disease, people cannot manage, so they refer it to us. So we have more number of bilateral patients in our institute. So looking at this, if you look at the most of the patients they fall in less than 5 years age group. Almost 90% of them are less than 5 years age group. This is our own data. Again, you look at the between 1 to 4 years, you find most of the patients in retinoblastoma. Now, most common symptom is leukocoria. That means the white reflex, whatever you call white reflex, the simplest, easiest way to diagnose a patient of retinoblastoma. You see a photograph when they are done for a birthday, you see a glow inside like a white pearl, white cauliflower thing that is seen within the center part of the eye. So the commonest symptom is white reflex or leukocoria, and tumor location intraocular is 90% in our series, and only 10% of extraocular tumors in 2074 eyes what we have our data. So, and most of the patients unfortunately fall into group D, and which originally called as group 4 and group 5. Now international classification is group D and E. This is most of the patients. If you look at 70%, 75% of them fall into group D and E. That is the challenging area that we need to salvage the globe, save the life and vision and the globe. So coming to the management, I think that's a brief introduction, and we have covered almost half an hour. So right, so let us so start on the principles of management. Very rarely some of the tumors can have spontaneous regression. Very small tumors, we can do local therapy and observe some of them. In the next follow-up, they disappear. The priorities of the treatment of retinoblastoma, we should remember, we should save the life. That is utmost priority. Next is to preserve the globe and possible vision. So in that specific order. So minimizing side effects is very, very important, because we know that we are dealing with the small children who are less than 5 years. So saving the life, preserving the eye, that's the globe, and salvage the function of the eye, that is optimal vision if possible. So what we see, which are only 10 to 15% of the patients come in group A and B, that is just a small areas of less than 3 millimeters in size tumors. They are dealt by ophthalmologists alone by doing local therapy, cryotherapy, thermotherapy, or laser coagulation. We'll talk briefly about these three therapies that is done by the ophthalmologist. So cryotherapy is a very good form of eradicating the disease. locally, but it gives a big scar. So that is a disadvantage of cryotherapy. So this part of the area we lose the vision. Photocoagulation is another best way of doing or reducing the tumor, but again this also leaves a lot of scarring and you lose the vision in that part of the retina. So now the latest and the most commonly used therapy is called thermotherapy, transpupillary thermotherapy. This is the best way to treat the patients, and this is a very local, good local therapy, and this causes very minimal scarring. So this is an area where we come into play as an oncologist to treat group 3, group 4, which is now called as group C and group D. So the chemo reduction, local therapy, plaque brachytherapy, external beam radiation, all these things fall in this category. This is an area where we need to save the life, globe, and the vision. So once they become late, in any way you're going to enucleate. So this is an area where we need to focus on, where these patients can be salvaged with the globe and vision. So let us talk about chemo reduction first. So most commonly, these patients have to go for chemo reduction because most of these patients come into group D and group E category, where we need to preserve the eye and the globe and the vision. So what does chemo does? It reduces the tumor burden and it allows the ophthalmologist to do local therapy. So it's a huge tumor becoming smaller, and then you do local thermotherapy, then you clear the issue. And then every 3 weeks, you follow it up and see how it is. And if you have new crops coming up or the old lesion is decreasing or not, we need to see very, very carefully. And then the local therapies would take care. If they are very small, it doesn't require further treatment. So it makes the job of the ophthalmologist easier. By receiving chemotherapy, the tumors become smaller. Sometimes the tumor is sitting right on the macula and you can't do thermotherapy. So you do chemotherapy, it becomes smaller. It can move away from the macula. Then you do thermotherapy. The standard chemotherapy now present day treatment is VEC, vincristine, etoposide, and carboplatin. These are the standard doses which are available on the net. You don't need to get into those details. These are very well tolerated by the kids. In some centers, we use it for 3 weeks interval. In some centers, we use it for 4 weeks interval. It's only because the child coming from a distant places becomes difficult for them to come back every 3 weeks, so it can be postponed to 4 weeks. But nevertheless, the recovery of the children is very fast. You can as well do it in every 3 weeks. So chemotherapy can be used as a neoadjuvant chemotherapy in group D and E, large tumors. We are not doing local therapy. You do only chemotherapy and then do focal therapy after 3 cycles or 6 cycles of chemotherapy. Concurrent, which we call it as sequential aggressive local therapy, wherein we do chemotherapy and local therapy simultaneously. The patient is taken up for UVA and you look at the tumor, you do thermotherapy, and the patient comes to the chemotherapy ward, and then we do chemotherapy. The whole idea is that when you do local therapy, there will be a lot of inflammation, increased vasculature, so the chemotherapy drugs reach that area faster and in more concentration. So that's an idea of doing local therapy followed by chemotherapy in most of the centers. Then adjuvant chemotherapy, this is after enucleation, which will come to you later. This is a classical case of massive tumor before chemotherapy and after chemotherapy. Before chemotherapy and after chemotherapy. So this is again a chemotherapy alone, large tumors, and then coming out of the macula, and then you can do local therapy. This is again a big tumors which is sitting right on the macula, and this can be reduced in size, which is reduced in size, and then you do local therapy. So all this group C, group D, when you use chemo reduction and do focal therapy, you're almost able to get 83% of these cases completely regressed with chemo reduction and focal therapy. So that means you're able to 90% of these eyes can be salvaged by doing this therapy. So the advantage of chemo reduction is allows salvage of the eye, maximize potential for residual vision, possibly prevents systemic mets, and delays and prevents pinealoblastoma, which is also called as trilateral retinoblastoma. So what do you do when you have a recurrent or residual or resistant retinoblastoma? So what happens in these cases, in refractory cases? There, it is very, very important to refer these patients to higher centers, tertiary care centers, where you do all kinds of high-end treatments in these patients without losing a hope. So we do high-dose chemotherapy, intravenous, intraarterial chemotherapy, periocular chemotherapy, intraocular chemotherapy, and salvage EBRT. So any of these, based on individual necessity, you can look at it and look at the options, feasibilities, and we can do these kind of treatment. Let us come to each one of us slowly. This is a periocular chemotherapy. You see that it's a direct injection, subtenon injection, which is given just below the tenon capsule, just above the sclera, and they respond very, you see that 70% eye salvage can be done versus not giving chemotherapy in these patients versus 30%. Now, intravitreal chemotherapy, when you have vitreous seeds which are not responding to standard treatment, that means intravenous chemotherapy may not reach vitreous cavity, so we do intravitreal chemotherapy, which in a recurrent cases, and when the vitreous seeds are not responding. And the doses are, the drugs are used are melphalan and topotecan, and the doses you can get it in the 20 to 40 micrograms at what we use, just 0.04 ml, that what we use by directly injecting the needle by the side of the limbus into the vitreal cavity. This is, which is very, very interesting and very gratifying results what we just started 3 years back, and we are happy to share our experience. This is called intraarterial chemotherapy. Either you do triple drug or 2 drugs, melphalan, topotecan, and carboplatin. The doses mentioned here, and these are the areas that briefly I'll show you the video. And this is the intraarterial chemotherapy, which is similar to the angiogram that what we do for the cath lab, which is done in the cath lab.
The ophthalmic artery. Prior to the procedure, a nasal decongestant, oxymetazoline, is administered to reduce the blood supply to the nasal passages. After the induction of general anesthesia, femoral artery access is obtained and intravenous heparin is administered. Utilizing fluoroscopic guidance, a 4 French guide catheter is advanced into
the common carotid, and then from there you get into the internal carotid, and you pass through that kink.
Under roadmap guidance,
you see that
over a microwire.
This is the ophthalmic artery. You go up, and then while pulling it down, it suddenly gets into the, while you pull it down,
of the ophthalmic artery
slowly pull it down
by slowly retracting the microcatheter,
and then you see that it suddenly gets into the, that's it. So that's the area, and you hold it there.
Superselective angiography is then performed
you
to
inject the drug,
of the microcatheter and assess the hemodynamic
and this is
flow patterns of
the difficult
artery.
part. You need to have patience, and each drug has to go infused for 20 minutes. So you're staying in the cath lab for 60 minutes, 3 drugs, 20 minutes each, and you have to give it for 1 hour.
Is assessed during the infusion by intermittent fluoroscopy.
So this is how it is done, and this is our own patient. You see the internal carotid artery, you pass the catheter above, and while pulling it down, that slips into the ophthalmic artery, and then you do inject the drugs through this. This is how this is another patient. You see the ophthalmic artery. In some patients, they are quite thick, and it's easier. In some patients, it's very thin, and it's very difficult. So this is an ophthalmic artery, and this is a catheter, and that is pushed into the ophthalmic artery, and then only you inject the drugs. This is the orbit, and this you see the gush inside the orbit. That means intense concentration of these drugs directly into the tumor. So this is another patient, and you see the gush after you do the injection. So this is sometimes, 90% of the times we do internal carotid artery, but sometimes if you don't find a ophthalmic artery properly, then you do through the external carotid artery, through the middle meningeal arteries. From the external carotid artery, you go into the middle meningeal artery and get into the temporal artery, go through the temporal artery as distal as possible, and then inject the drug. So inject the drug. So this is how the gush happens inside the orbit. So these are the multiple retinoblastoma patient scans, and you see an ultrasound images, the massive tumor before and then after one cycle, and you see after second cycle and after third cycle. These patients have to be mentally prepared and counseled for 3 doses of intraarterial chemotherapy once in 3 weeks. So this is before and after. So this is how dramatic responses we see with intraarterial chemotherapy. So we have done in 124 patients, and then you look at each patient 3 times. So it's around 330 cycles. Bilateral cases, 3 cases. Internal carotid artery is 90%. Through external carotid artery is less than 10%. So this is done at Apollo Cancer Institute, Hyderabad. So then you come to plaque brachytherapy. Last time we did discuss very extensively on plaque brachytherapy, so I'll be brief on that. So indications in retinoblastoma would be chemoreduction failure or when there is a recurrence. Rarely as a primary treatment. That you should understand that this is not a primary method of treating the patients. But the tumor has to be less than 60 millimeters diameter and less than 8 millimeters thickness, because we use most often ruthenium brachytherapy. And the doses you all know, 4,000 to 5,000 centigrade, and 90% success rate is what we see in these tumors. So commonly used are in the country, in our country or across the globe, are iodine and ruthenium. Iodine has got gamma rays, and it's very difficult. You need a lot of protection in the theater as well as in the patient isolation. So ruthenium is safest and easiest and the best. And also major advantage of ruthenium is the half-life is 1 year. So you don't need to change the source so often. So we do it once in 2 years. Now the good news is that we used to buy ruthenium from outside Germany. Now we are getting the prepared at our own center in DRC. And so we are very, very happy. And not only that, that this is affordable. And if you look at 11 lakhs, what we used to spend earlier, now it is only 50,000. And whoever wants to start, the BRC is ready to give free of cost for the first plaque to any of these institutes who want to take up this. And this is absolutely quality assurance has been done. We formed a team in the country for the development of this plaque, and we are very, very happy that we got out our indigenous plaque in India. And this is gone through multiple quality assurances. And finally, the first case has been done at Hyderabad on August 21st, 2019. We are very, very proud that we could use our Indian, and this is a quality assurance from all angles, horizontal, vertical, and V plane and the H plane, the dose distribution. This is compared with the B big plaque, ruthenium plaque from the Germany. It's 100% matching with the source which we used to buy from outside. So how does this procedure happens? Plaque brachytherapy is first you do the tumor dimensions either by an ultrasound, sometimes by a CT scan or an MRI scan, and then you draw it on the retinal diagram which is on the computer and the dosimetry screen, and then the plaque can be placed according to, and we can move it with the mouse and then put it according to the area of the tumor, and we get a dosimetry. And then after doing the computer planning, then we take up for the placement. We call it as conjunctiva. Conjunctiva is cut by the side of the limbus. It's called conjunctival peritomy. And then this is a dummy plaque. This dummy plaque is placed inside first, and then we do an ultrasound to make sure that the dummy plaque is right on the tumor. Then the ruthenium plaque in the red country is removed and placed exactly where the dummy plaque is placed. And we look at we already with the dummy plaque, we mark an eye here, and this is area which matches with the ruthenium plaque here. And then we suture it from here to this eye to this area, which is exactly the same as the dummy plaque where we placed it earlier. Once this is, you look at the suture being placed here to this black mark which is placed earlier. And then the conjunctiva is sutured and the patient is kept in an isolation for the required amount of time as per the dose calculation. Now the proper care is taken, and then plaque is removed after the exposure time. Sometimes under local anesthesia we can remove it. So the patient is asked to come after 4 to 6 weeks to see the response, and 2/3 of the patients have are known to have a complete response. 90% of them would have response, but 65% of them would have complete response. This is pre and post plaque brachytherapy. And this is the patient, is the first patient which was done in 2002. I'm so glad this patient has been advised enucleation. Bilateral retinoblastoma, one eye is already enucleated. The other eye was supposed to get enucleated, and they had come to us. And I'm glad that this guy is in 15 years later, you look at this is a processes and this is a normal eye, and he's still alive with a normal complete control of the disease. So plaque brachytherapy, in our cases, we have done 232 plus cases at Hyderabad, and you will melanomas, retinoblastoma, different tumors have got different doses. And retinoblastoma, as I said, 2/3 of the patients would have responses with this tumor. So briefly about external beam radiation in intraocular retinoblastomas, salvage EBRT only in refractory cases, not as a primary modality of treatment in retinoblastomas. So when all other modalities fail, then only you think about external beam radiation. So intraocular retinoblastoma, role of external beam radiation is very minimal. Only after the primary treatments exhausted and there is resistance of disease, then you do external beam radiation to the intraocular tumors. Extraocular retinoblastoma, anyway you require radiation. We'll come to that in the next few slides. So salvage EBRT tumors with RB gene mutations appear to be more sensitive. So bilateral retinoblastomas respond better than unilateral retinoblastoma. Should keep this in mind. Most of the times you try to enucleate when you have a bilateral retinoblastoma. So you can give a fair trial of external beam radiation in these patients. So likelihood of salvage is almost 67 to 83% in these patients with external beam radiation. So external beam radiation still has to be the last option, is avoided as much as possible because of facial deformity and because of second cancer, especially in hereditary type and bilateral retinoblastomas. So most of all these patients have to be treated under anesthesia, and you look at this 2D external beam radiation. We take a lateral film, and then based on the film, we do a styrofoam cutter and design a lead block. And you see the lead blocks, anterior part of the shielding is complete, and posterior part is the shape of the eyeball. This is anterior beam block. Posteriorly, part of the optic nerve is treated. This is how the beam is designed. And bilateral retinoblastoma can also be treated with this lead blocks if it is a 2D. And then we can design, because way back we earlier used to treat with 2D, and you see the pencil beam block we used to design and then treat these patients with the pencil beam block in those days. Now with 3D CRT also, this is the CTV volume of the globe intraocular retinoblastoma, the entire eyeball behind oris areata. So you have to draw the CTV behind the lens, behind the oris areata, up to 1 centimeter of the optic nerve. So this is the entire globe, 1 centimeter of the optic nerve behind the oris areata should be your clinical target volume. And a post-operative orbital retinoblastoma, that means the tumor is already out of the eyeball, then you have to include the entire orbit, optic canal, as well as the ipsilateral cavernous sinus. So this is how the CTV volume of the orbital RB has to be done. Now, IMRT EBRT planning, this is very important because you need to have a target volume in these patients. When you have a post-operative case, entire orbit, optic canal, ipsilateral cavernous sinus, inferior orbital fissure and superior orbital fissure. Whereas for the intact, there is intraocular retinoblastoma, the CTV is entire eyeball behind oris areata. That means you are sparing the cornea and the lens, and then up to 1 centimeter of the optic nerve. So in the lateral view, CTV volume, and this is how end of the day after you treat retinoblastoma, intraocular retinoblastoma with IMRT, cornea and lens sparing IMRT. So you have a bilateral retinoblastoma also. It is safe that you can treat these kind of patients with the latest technology. What we have, volumetric arc therapy, entire eyeball behind the oris areata up to 1 centimeter optic nerve. In a single go, we can treat. And this is for the ophthalmic people who have logged in. This is easy for the radiation oncologist to treat. You see how the patient is being treated. 2 globes in one single go in 1.2 minutes. Both the globes and the result is like this. So you see the anterior part of the eyeball is spayed, cornea and the lens are spayed, and the entire globe with 1 centimeter of the optic nerve is treated bilaterally in a single go. So one thing that we should remember, that these children, we should keep the eyes open to reduce the dose to the cornea. Eyes should be wide open. You cut open the immobilized device. If the patient is unconscious or in anesthesia, you plaster the eyelids up and below onto the aquaplast and keep the eyes open. Radiation sequelae in this era, we all understand these are mega voltage, so the reactions are very less. And these days we do lacrimal gland sparing, IMRT, so the dryness also is very less frequent. Lens is not an issue. You might develop a cataract at a later date, and that can be possible to extract it. And the cornea, we hardly get keratitis because the doses what we deliver for retinoblastoma is 45 gray, and cornea can tolerate up to that. And also with the open eyes, we hardly get such kind of doses. So retina and optic nerve also can tolerate reasonable good doses, and this is how we are safely can deliver these things. Finally, on the enucleation part, once the tumor is not salvageable with any kind of these refractory retinoblastomas or group E, that means group 5 tumors, massive tumors with hemorrhage and all. So those kind of tumors have to go for enucleation. And what happens then? However, the enucleation rates have significantly come down in the recent times, and enucleation is done only in a secondary glaucoma when there is anterior segment involvement and seedling happens, and worse in an advanced bilateral retinoblastoma. We should all remember that enucleation is not the end of the treatment. It is just the beginning. We need to look at the pathological parameters to get the cure rates in these patients. Very, very important. So when you have an anterior chamber infiltration or trabecular meshwork infiltration, ciliary body infiltration, or choroid infiltration, or if the optic nerve is invaded or extravascular infiltration is there, then you also need to add radiation treatment in these patients. Otherwise, all these patients would go for adjuvant chemotherapy. So this is anterior chamber infiltration, iris ciliary body infiltration, and these tumors, and this is an optic nerve infiltration. These tumors certainly would require, see, you look at the most common involvement is optic nerve. These are the high risk factors, optic nerve and choroidal invasion. So these tumors need to be given adjuvant treatment. And you will see 52% of these patients who undergo enucleation would have high risk factors. So these patients would certainly require chemotherapy 6 cycles. When you have extraocular extension or optic nerve transaction, then it goes up to 12 cycles of high dose chemotherapy and sandwiching radiation after 6 cycles. So that is how these patients, then only you get the results what we are showing, 90-95% survival rates. So when you have optic nerve invasion or scleral extraocular extension, then you require external beam radiation as well, apart from 12 cycles of high dose chemotherapy. Does adjuvant therapy help? Certainly. So if you do not do adjuvant treatment, 24% of these patients, this is again our own data, 24% of these patients would have metastasis or local recurrence. Only 4%, that is 2 patients had metastasis when you receive adjuvant treatment. Stage 3 retinoblastoma, earlier we used to do directly exentration. The mortality is to be almost 70 to 90%. Now the latest protocol is you start with neoadjuvant chemotherapy, high dose VEC protocol, then only you do enucleation, and then you do orbital EBRT, external beam radiation to the entire orbit, the volumes which I already mentioned, then continue high dose chemotherapy for 12 cycles. Then the mortality from 70% increases to survival to 70% in this orbital retinoblastoma. Such massive tumors have a gratifying responses with chemotherapy, do enucleation, radiation, and then put prosthesis. And this is a child with prosthesis. So massive tumors respond dramatically with this chemotherapy. So basically, if you look at the treatment modalities, you look at systemic chemotherapy, 60% of them would certainly get chemotherapy, and still you get 35% of them going for enucleation. because majority of them come in very late stages. So orbital retinoblastoma and group E patients have to go. We can save their lives, but we have to go for enucleation. In a metastatic RB, CSF positive patients, then we do intrathecal chemotherapy. We start with intrathecal single drug methotrexate and 4 doses, and then do CSF analysis. And if it works out well and the CSF becomes negative, you do 2 more doses as a consolidation. After 4 weeks of methotrexate, if you still have CSF positivity, we change that into triple drug chemotherapy for another 4 doses of methotrexate, cytosol, and hydrocortisone. But in advanced cases of intracranial extension, metastatic bone, we do high dose chemotherapy, but that will become palliative only. None of these patients can be salvaged, can be cured. We can only control the disease for some time, give palliative CT and RT, or supportive symptomatic treatment. I have never seen a patient surviving with the metastatic disease. So these have dismal prognosis. So it is quite gratifying after we started this new dedicated ocular oncology department. You see the results from various centers. Now the results with our centers on par with international standards. Almost 95% of these patients, this was a data of 1,000 patients, 95% of them, and these are 1,450 patients, 92% of them are alive and well. So that is what is very, very important. We are able to salvage 92% of these patients in from stage 1 to stage 3. So follow-up is very, very important, as we all know, because new tumor formation is quite common. Even after getting complete remission, these patients can get up new crops of disease. We need to understand that, and we should be very, very careful in following up these patients till the age of 4 years. So evaluation under anesthesia need to continue. When you do local therapy or any kind of focal therapy, you need to follow them up, and you should be very, very careful. Even after complete remission, we ask these patients to come every 6 to 8 weeks till the age of 4 to see if there is any local recurrence, and we immediately salvage them with local therapy. So patients with hereditary retinoblastoma, they have increased high risk of secondary malignancies. That we should keep it in mind. Most common are osteosarcoma, PNETs, fibrosarcoma, and melanomas. Especially when these patients undergo with radiation, they almost have 70 to 80% chance of developing second malignancies, especially in the area of the radiation, especially when the RB gene is mutated. So long-term follow-up of these patients is mandatory, with a special vigilance for patients with the germinal mutations. Overall outcome, overall survival, as we mentioned, this is our own data. So we are really proud of having a tertiary care center here. And overall survival is 92%. 36% of these eyes still needed enucleation. 55% of these eyes undergo enucleation. You should remember that 55% of these patients, of these 36%, do require adjuvant chemotherapy and radiation to get that 92% survival. Chemo reduction and salvage of the eye is 90% when you use chemotherapy. So in an Indian scenario, unfortunately, you still have 80 to 85% patients in a primary and healthcare center. So the results are very poor. 50% mortality is what we are noticing. But if these kind of patients come to centers where there are dedicated treatments available, where you can do the protocol-based management, then the results will be almost 90%. What is important is a good tandem between coordination and understanding between ophthalmologists and radiation oncologists working together in tandem. That makes a huge sense. You're discussing in and out which is better first, which is later. So what kind of treatment need to be done in that particular patient are very, very important to get the best results and to work as a team. So bilateral retinoblastoma, one of these patients is, she comes for our cancer survivor program. She sings songs, and we're so glad that she's a teenager now. So bilateral retinoblastoma, we could save her life and vision. So chemo radiation make the difference in retinoblastomas, and we all know that the eyes are the most important, one of the most important organs in the body, and we need to protect them. Thank you very much for the late evening, and thanks for not yawning, although it almost took 1 hour class. I'm glad that that you could have so much of patience to listen to me. Thank you very, very much.